morning, everybody. I'm Susan Howards, an attorney in Brookline, and this is Brookline Interactive Cable's show dedicated to domestic violence. But during COVID, we have expanded the topics we are covering. With us today is Dr. Jacobs, internationally renowned expert on suicide. He's a member of the McLean staff of, I believe, Mass General. He's written extensively. He's called on extensively to discuss suicide prevention and do assessments. He founded the National Depression Screening Group and Safety Suicide Protection. He received the Lifetime Achievement Award from Mass Coalition of Suicide Prevention. Welcome, Dr. Jacobs, and a big thank you to you. Is there anything I left out in your background?
No, I think you've described it. The affiliation is just with McLean Hospital. McLean Hospital and Mass General are connected, but I'm on the staff of McLean. And to just say that I've been involved with studying and treating suicidal patients since the first days of my residency in Boston in the early 1970s. And I think I commend you for addressing this very important topic, because unfortunately, for the last 10 years, the suicide rate has increased by nearly 35%. However, in 2019, the figures were just released. It was the first time in 10 years that the suicide rate has dropped a bit. So it's certainly encouraging news. I think, programs such as yourself and just the advances in treatment and awareness, the multiple nonprofit organizations, the dealing with stigma, and the clear understanding of suicide, hopefully accounts that we're headed in the right direction.
So would that be your assessment of the current status of suicide in the U.S., what you've just relayed?
Well, as I said, there has been this increase, quite traumatic. What are our understandings as to why? Certainly the economic crisis, the opioid crisis, you mentioned domestic violence, the change in relationships, unemployment, and it's clearly been, we're concerned about what's going to happen during the COVID crisis. We do not have any hard data yet, but it's certainly something we're looking out for, because we do believe that there's been an increase in depression and anxiety during this period of time, but we do not have any firm statistics that there's been an increase in actual suicide.
Dr. Jacobs, with what you've just said, and I'm sort of ignorant about this subject, I'll be very honest, what can be done to help people, and what are the myths that get in the way of helping? And I have to ask another question, just as sort of an ignorant layperson. I don't know if you can answer this. What are the signs? What should I be looking for, say, in clients? Because I had 3 call me yesterday, desperate about the economic situation.
Well, I think maybe we would start with the signs before we get to the myths. And so one way to think about signs, they're both verbal and behavioral, and yet we don't expect people to be clinicians, but it's good to separate out the 2 types of warning signs. And sort of the bottom line is, see something, say something, much like the messaging for concern about the welfare of others. But first of all, making suicidal statements, such as, I don't want to live anymore, I don't belong to live. I'm not worthy of being alive. There's no point in my being alive. You would be better off without me. And actually making some plans. So if someone says, you know, I'm thinking of killing myself, and here's how I'm going to do it, these are all, this is something that needs to be taken seriously. Repeated expressions of hopelessness or helplessness, that I don't believe my life is going to get any better. There's no point in getting help because it's not going to do any good. Feeling like a burden, that happens to be, you know, there's been increased attention to this phenomena in which people say, I feel like I'm a burden to my family, and what I'm going to do is relieve my family of that burden. When one hears that, one's ears should perk up. People who are severely mentally ill may hear voices telling them to kill themselves. So again, that's something that if someone says that, that needs to be taken very seriously. And that's another, maybe I'll digress for a moment, that
Sure.
when someone hears these serious statements, one has to treat them like one would treat a medical emergency. As if someone is choking or complaining of chest pain, you need to respond, and it could the response. And I know there's the number for the National Suicide Prevention Lifeline, the 1-800-273-1255. Contacting if a person's in treatment, contacting the clinician. And then I think if there's no response, bringing that person to an emergency room. And if you need assistance, then you call 911.
Dr. Jacobs, can I just ask you a question
Sure.
about this? Do people who are seriously thinking about suicide, do they share their thoughts, or do they keep it sort of quiet and just make their own plans, number one? And number two, if they share their thoughts, is that a sign that they really would like some help or no?
Well, these are both two very important questions. First of all, the issue of sharing. Our research shows that anywhere from 50 to 75% of persons who go on to die by suicide have communicated their intention to a significant other, but that person, not out of any malintent or anything, does not respond. So for example, someone may say, if they hear a suicidal statement, they may inadvertently say, you know what, Johnny, we love you. Don't think like that. Go to bed, and tomorrow will be a better day. So that's why I make it analogous to a medical emergency. If someone was choking or having chest pain, one would want to get an evaluation right away. The other is, and this really gets to, if one notices someone who appears to be very despondent or having tremendous anxiety or even showing extreme rage, asking someone directly, are you thinking about suicide? Because, and this does get to one of the myths, people are concerned, if you ask someone about suicide, will you be putting the idea into their head, into their mind? The answer is absolutely not, because part of what happens when people are suicidal is they begin to feel disconnected from others. They begin to feel not understood. And asking someone if they're suicidal actually allows them to feel that they are understood, that they are connected. So that's really sort of a myth that really needs to be addressed head on.
Wow, that's good to know.
Um,
I think I would be afraid to ask that, Dr.
Yeah.
Jacobs. I
Well,
would be really afraid. What if I messed up and I didn't get him the right help in time?
No, there is no messing up with that question, but it's a concern. That's why there have been actual studies where they looked at they examined this in a study where they looked at what happens when someone asks about suicide, and in fact, there's evidence that it lowers the suicide rate, and there's
Oh,
no
good.
evidence that it increases the suicide rate.
Okay, that's good to know. When you say if somebody's enraged, could you elaborate on that a little bit? Because you find that in domestic violence a lot. Not that
Well,
we're
you
talking.
know, again, it has to be taken in context. In other words, in and of itself, someone who's angry about something that may or may not be someone who's suicidal. But if
Okay.
you take it in the context of that they've had a severe loss, that you've noticed that their attention to cleanliness has decreased dramatically, that they've perhaps increased drinking or the use of substances, or they've engaged in risky
Mhm.
behavior. These are other things you look for that would go that, so not to isolate extreme rage, but it's part of the picture that we look for. And again, all these, if one sees this, then one asks directly, you're upset. Are you thinking about suicide? And we have to not be afraid to ask that question and to use the word suicide, to use the word, are you thinking, expression, are you thinking of killing yourself? I know it sounds, dramatic, but suicide is it can be dramatic and needs to be addressed head on.
What are some of the other myths, Dr. Jacobs, that we should be aware of and that we should deal with?
Yeah. So a second myth is when someone appears to be improving after hitting rock bottom, their risk of suicide is decreased. So someone may notice, well, they've begun treatment for depression. They seem to be doing, they were really bad and now they're improving, and the risk of suicide must be decreased. Well, actually, it's quite the opposite, because what we know, unfortunately, is that energy improves before mood. So that even though someone may appear to be a little bit more active, a little bit more alert, their mood is still depressed, and inadvertently, suicide can actually be increased during this time period. And I stress that only because the need to continue with treatment is actually one of the issues that people need to attend to. It's not any different from, when we're told to take some antibiotics, after a few days we feel better and people want to stop. Well, you need to take it for the whole time. And it's the same with depression. There is people may start to feel better in the first couple of weeks, but they need to remain in treatment for anywhere from, at least initially, from 3 to 6 months. And it's not just with medication, it's also with the talking therapy that goes along with it. And then the clinical team will help the person make a decision about how best to go forward after 6 months or even a year. So it's not something where one starts treatment, they feel a little better, and then it's okay to stop. Yet it doesn't need to go on necessarily for years, but certainly it needs to go on for more than just a few weeks.
Dr. Jacobs, could you just discuss for a minute the relationship, if there is one, between depression and suicide? I'm not sure I recognize depression in my clients.
Well, again, that's another important question. One way to think about depression is, first of all, that it's an illness, not a weakness, and that it's
Mm.
we call it a clinical syndrome that has 9 factors.
Oy.
There's depressed mood, loss of interest in usual activities, changes in biological functions such as usually decreased sleep, decreased energy, decreased appetite with weight loss, uh, being agitated or extremely slowed down, having problems with concentration,
Mhm.
feelings of worthlessness or hopelessness, and the most serious, having thoughts of suicide. Uh, Depression, bipolar depression, mood disorders are the number one risk factor for suicide. That is, if one looked at 100 suicides, anywhere from 50 to 70% will have had an underlying mood disorder. Now, that doesn't mean that everyone with depression is, that there's some sort that they're a fatal. It's a fatal illness. It can be, and that's why treatment is so important. And that's been one of the advances. And even after all these years, only about 50% of persons who experience depression get treatment. And
Dr. Jacobs, do you think it's because they don't recognize that they're depressed, or do they think it's temporary? And one more part of this question, is suicide and depression, is that age exclusive? In other words, can little kids be depressed? And does it escalate as we age?
well, there are a lot of questions there. Maybe I'll start with why people don't seek treatment. I think the major reason is they think they can do it on their own. There's also stigma. There's also access to treatment.
Right.
So it's very complicated. Also, the illness itself may deter people from getting the help they need. In other words, they begin to feel that they're not worthy of getting help. They feel it's hopeless. So why seek treatment? The issue of getting a person to treatment can be complicated that way. And your other question was regarding what the
Age, is it age specific? Can little
age.
kids be depressed, or does it get more likely as we add the years to our life?
Well,
In other words, our old people.
so there is certainly young people can get depressed, although it tends to be an illness that comes on anywhere between the ages of 18 and 30. And that the suicide rate generally increases with age. Now, the recent increase in suicide rates, there have been more young people, when I say young people, even under the age of 15, who have committed suicide, who have died by suicide. And then I should say that's when I said committed suicide, we no longer say those words. It's died by suicide, in part because we want to get out the message that this is not something that's sort of analogous to a crime. You commit a crime and you die by suicide because more than likely you have an underlying illness.
Okay.
The suicide rate of young people is still very low, although
Good.
clearly it's very tragic. So you read about suicides that occur in young people. You just see that the son of the Congressman Jamie Raskin. His son recently died
Oh,
by suicide in the past couple of weeks, and I think he was a young man in his 20s, but had mental illness, and it's always a tragedy. Um, and to try to recognize that mental illness is, a major risk factor for suicide, and that with treatment, the majority of people who get treatment do not die by suicide.
mm,
But when those of who do, it's not because they're weak or it's their fault. It's that their illness has created such intolerable mental pain
ooh,
that suicide becomes the only option. And it's something that's sad and tragic. And,
mhm.
I feel for the congressman and his family, having to mourn. And yet I see the strength that he has at this current moment where he's leading the impeachment team.
What about the guilt for those who are left behind, Dr. Jacobs?
Well,
Like,
sir,
like the congressman and
yeah.
like some of the families. I mean,
Well, I think the guilt is something that does happen among, for survivors of suicide. But to try to really put it in perspective, it's because on the one hand, it's not uncommon to ask oneself, what could I have or should I have been able to do
exactly.
more? And that's where to really understand that this was not just a choice that the person made. It's not that that your last phone call you had a disagreement. It's to really put it in perspective and say, when someone dies by suicide, most of the time it's due to severe underlying mental illness,
Oh,
which has then led someone to have, as I mentioned, intolerable mental pain, but
ooh,
also to feel disconnected from those around them. And that even reaching out by loved ones may not be able to penetrate this wall of, if you want to think about it, this wall of pain. And I'm sometimes asked, what is this pain like? And
I was going to ask you that. Yeah.
to think about it, if there were 100 people in a room, and each person was saying, was asked to ask themselves, what is it like to feel mental pain? They might have their own
Hmm.
interpretation of that, but to imagine the if you multiply the 100 people, their pain, and you put it into one person, that's the degree of pain. In other words,
Wow.
think about it as a collective pain that literally is unbearable, so that there is no other choice for that person at that moment. And then now the other side of it is, a myth is that if someone's decided to suicide, there's nothing that can be done. Well, as someone who's been involved in the care of suicidal patients and understanding suicide my entire career, I don't agree with that, uh, because a way of thinking about this is that there's a phenomena in suicide we call ambivalence, the wish to die and the wish to live, and
Hmm.
that it remains a struggle for people, and that up until the last minute, that struggle is going on. And, there's this vignette of a man who jumped off the Golden Gate Bridge, um, and he survived. And so he's told his story because he said as soon as he jumped, he wished he hadn't, and he miraculously survived, and he's spent his sort of career he ended up getting a safety net under the Golden Gate Bridge, and has been a real advocate for
Wow.
dealing with suicide. But he said, as he was walking along the path on the bridge, if someone had stopped him and said, "How are you doing?" he might not have jumped. So intervention up until the last minute can matter. But on the other hand, that sometimes can sort of increase the guilt of a survivor, saying, well, maybe if I had done more. And I think to really understand that those that end up dying by suicide, that their own internal battle, the wish to die has won out because of the pain they feel. And that there wasn't at that particular time, more than likely there wasn't anything that would have made a difference.
So Dr. Jacobs, what I think I'm hearing you saying is that connections and relationships can really make a difference if we pay attention and we jump on signs that maybe someone in our world is considering suicide seriously. I mean, I have a client now who's in deportation proceedings, and she has 2 babies, and she said, if I'm deported, which is likely, I'm going to commit suicide in my home country. And I said, you don't mean that, do you? I don't know if that was the right thing to say. And she said, yes, I'll take my babies, I'll give them to my mother, and I will kill myself.
Yeah.
And I didn't know she's in treatment for depression, teletreatment over, I don't know what, the internet or the computer or whatever. Right. And I didn't know if as an attorney I should get involved. So I didn't, because I keep my boundaries clear. I know very little about this subject, or I should suggest maybe she needs a different treatment, or maybe she needs, I didn't know what to do, quite frankly, but I was sort of taken aback that she was vehement about her statement.
Yeah. Well, again, without knowing the specifics, but
right.
One thing you could say to a person like this, have you expressed this to your treaters, to really, and it's sort of up to you, but you could reach out to their treaters and say, I'm involved with your patient, mm-hmm. your client, mm-hmm. and I just want you to know what they have communicated. Now, a clinician may not be able to give you any information, but
that's fine.
A clinician can receive information, and that's an important point. Confidentiality is paramount between a healthcare provider and their patient.
Right.
But when it comes to the issue of life and death, sometimes, certainly me as a psychiatrist, I have to, involve family members. I have to involve other, emergency rooms or right. The police. But and I've had family members call me to express concern about their loved one. And I tell them, whatever you tell me, I will be sharing with your loved one.
Right.
But I can listen. I don't say, oh, that's interesting, because we were talking about that last week. You're not allowed to reveal any information about your patient right. / client, but right. you can receive information which could be helpful.
That's a good suggestion. Thank you. In the remaining few minutes, are there any other myths you'd like to dispel and give us some ammunition to go forth and hopefully help those in our practice and in our lives?
Well, I guess it's just it's related to the first question you asked me, but there's a myth that most suicides either happen without warning, or people who talk about suicide are not actually likely to attempt suicide. And in fact, that's not the case. that, first of all, in terms of happening without warning, usually there are these verbal or behavioral clues that that occur, and for people to be aware of those and to respond, and that to take communications of suicidality or communications about wanting to die seriously, and that people should not be expected to be put in a place of trying to evaluate the seriousness of it.
Right, right.
That now it could be, if someone has a long-standing history of every time they get upset, they say, if you do that again, I'm going to kill myself. That has to be taken in context. But the majority of people who, when they're distressed, may say this, and it just needs to be taken seriously.
Okay.
And the good news is that we've become, as treatments improve, progress, it's a combination of our medication and our therapies, and the talking therapies and the different kinds of talking therapies, and we're not talking, as I said, it's not long term, it's not overnight either. It's to think about it now that there's a focus on what we call suicide focus assessment and suicide focus treatment, and the good news is that we're making advances, and if 2019 is an indication, we seem to be headed in the right direction. But given the current stressors in our country and the pandemic, we need to keep being vigilant.
And even more vigilant given COVID and the isolation of all of us, including kids sitting in front of their computers, supposedly, because I know in my family, when they're supposed to be sitting in front of the computers, they're playing games during school time. So that's a huge stressor. Dr. Jacobs, I can't thank you enough. And I just want to go over the resources you gave. The National Suicide Prevention Lifeline is 1-800-273-1255. And the crisis text line, text HOME to 741-741. Dr. Jacobs of McLean Hospital, I can't thank you enough. And I hope that you will return, because as we progress through COVID and vaccines, and maybe the surges won't be so surgy, I hope you'll come back. Thank you again. And that's it for the Safety Net this week. Bye-bye.
Okay. So long. Thank you.